All right, sounds good. Can you all hear me? You hear me okay? Okay, I think my husband's vacuuming downstairs, so I'm asking him to please stop vacuuming. Give me just 1 second. And then I will also share my screen right now too. Let's see. Let's see. I can do this. Perfect. You share. Let's see. Whoops. All right, can you all see that? Can you see my first slide is okay?
Yes.
All right, perfect. Okay, so thank you all so much for being here with me today. My name is Thea Swenson. I'm a second year in physical medicine and rehabilitation, which is a specialty that's also known as PM&R. And I'm here, let's see, to tell you a little bit about our field. This is an outline of my talk. I'm just going to give you an introduction of myself, of where I came from and how I got here. And then we're going to talk a little bit about physiatry and go over a few case studies to give you an idea for the conditions that we see and what we do as physiatrists. And then we'll talk about how you become a physiatrist and why you all should think about becoming one. I know you're all earlier in your careers, but I heard about physiatry early in my career. So hopefully you get this exposure and your interests, you have some interest in our field. And then finally, I'm going to end with some advice that I have based off of the things that I have learned throughout my career. So just a little bit about me. I was born in Los Angeles, California. Both my parents are Vietnamese. And when I was 3, we moved to Denver, Colorado. That's where my brother was born and where I spent most of my life until I left for college. And I went back to California for college at Stanford University. And while I was there, I spent a lot of time trying to figure out what I wanted to do with my life. I didn't enter college knowing that I wanted to become a doctor, although I did have several relatives who are physicians. Neither of my parents were doctors, and I never really considered it until I had tried a lot of different things. One of the things being thinking about becoming an engineer. So I majored in product design. It's actually a very unique major. At Stanford, it's product design is a subset of mechanical engineering, but we focus on human factors and creativity as well as aesthetics. And we also studied design theory and worked with various companies. So very, very different than kind of the basic sciences, medical, pre-medical track that many people follow. And I really loved that major, but when I graduated in 2013, I wasn't sure what I wanted to do. So I worked for some tech companies in the Bay Area, one of them being Doximity. And I did some research projects at Stanford as well too. And during that time, I actually stumbled upon some physiatrists at Stanford, and they were teaching this class called lifestyle medicine. It was a combined musculoskeletal class as well as focusing on some lifestyle medicine issues such as sleep and nutrition. And they took me under their wing. So I started doing some research with them. And after getting to know them a little bit more, I became more interested in medicine as well as physiatry. So I then went back and did some of my pre-med requirements. I ended up going to medical school 2 years later back at the University of Colorado. And currently I'm a second year at Vanderbilt University in physiatry. And so looking at all of this, you might think that I always wanted to be a physiatrist even before I went to medical school. And you might be right. So I'm hoping to tell you all a little bit about physiatry so that just like my mentors at Stanford, I might inspire some of you to become physiatrists or at least look into our field and see the opportunities that are available, not only for pre-meds, but NPs, PAs, lots of things that you can do within the broad spectrum of physiatry. So what exactly is physiatry? It comes from the Greek words physiokos and atresia, which are the combined meaning of physical and the art of healing. And physiatry, or physical medicine and rehabilitation, or PM&R, we go by all of those terms. It's a broad field that specializes in a philosophy as opposed to an organ system. So that is something that drew me into this field, and it makes our specialty very unique. So as opposed to other specialties that focus on organ systems, such as the heart or the lungs or the kidneys, as well as the diseases that correspond to those systems, we actually focus on prevention, restoring function, independence, and maximizing quality of life. So we're considered the medical experts when it comes to maximizing function that has been lost through injury, illness, or other conditions. We use a very holistic approach in understanding to our patients, and we work in teams with other healthcare professionals, which I'll go into in a little bit more detail later on. Physiatry is one of the newer subspecialties of medicine. Our field really began to develop during World War I, as well as the World War All right, sorry about that. I don't know if that was my internet or what happened. Are we all back on here? We're all okay? Okay, good. All right, so if that happens again, I do have a backup plan. I'll just get onto my phone's Wi-Fi, because I don't know if my home Wi-Fi just can't handle some of the Zoom meetings, but I will go back to this. All right, let's see. I can't see you all. Let me see if I can share my screen one more time. So perfect. All right. All right. Are we all back on right here? Okay, perfect. So let's go back. So I think we talked a little bit about this. Long story short is that we're a newer specialty within medicine, first recognized in 1947. And so some of the conditions that we treat as physiatrists, we treat a broad range of conditions, and we work with diverse patient populations. So in theory, any patient can benefit from a physiatrist. That includes everyone from Olympic athletes to tetraplegics, stroke patients, traumatic brain injury patients. And here are just some of the conditions that we treat. So in the neurologic system, we treat brain injuries, spinal cord injuries, stroke, multiple sclerosis, as well as Parkinson's. Within the MSK system, we treat patients with amputations, osteoporosis, arthritis, work and auto-related injuries. Pain is another big symptom that we treat, and that pain can come from bones, joints, muscles, ligaments, tendons, bursa, back pain. We also oversee rehabilitation programs, for example, for patients with primary cardiac and pulmonary problems. So this can include patients who are either post-transplant, who recently had a big open heart surgery, who have end-stage COPD, and others. So very broad in the conditions that we can treat. And some of the diagnostic tests that are within the scope of practice for physiatrists include X-rays, MRIs, and CT scans. Ultrasound is a very new and kind of upcoming modality, and as we can put it, for diagnosing certain pathology. So it's a very important skill for us to know as physiatrists. Nerve conduction studies and EMG are another skill that are relatively unique to our training, and is something that we have experience in. So nerve conduction studies evaluate the function of motor and sensory nerves. This helps us distinguish the location of a nervous system lesion. And EMGs, or electromyograms, can help distinguish whether weakness is due to muscle or nerve dysfunction. So that's either myopathy or neuropathy. And we use EMG to just diagnose these conditions by inserting very thin electrodes into the skin and detecting the electrical potential generated by the muscle cells, which helps us elicit pathology. I'm going to skip over this video. I think I have a short video, but we'll skip over that for today. But if you have any more interest in knowing about EMGs or nerve conduction studies, we can always talk about that a little bit later, or you can reach out to me afterwards too if you want to talk a little bit more about that. But for now, we'll just kind of keep moving forward, and we'll talk about treatments that we offer as physiatrists. So physiatrists do not perform surgery. We're a non-operative specialty, and we treat conditions in the form of several modalities. So one is injections. We do a lot of peripheral joint injections, both to diagnose and treat disorders, which can also be done under ultrasound. We can also use trigger point injections, and that's kind of more of an adjunct treatment for myofascial soft tissue pain. Certain specialties within PM&R, like interventional spine, use fluoroscopy to provide non-surgical pain relief for back pain. We also manage spasticity, which you can understand spasticity as this like stiff or rigid and tight muscles. And we manage that by using Botox and other injections. We also prescribe oral medications and manage baclofen pumps. And like I mentioned earlier, we oversee rehabilitation programs by working in interdisciplinary teams. So other members of our team include physical therapists or PTs, occupational therapists or OTs, and speech language pathologists or SLPs. So physical therapists, those specialists help patients improve movement. Occupational therapists work with patients to improve and maintain the skills that they need for daily living as well as working, doing things like getting dressed and using a pencil. And speech language pathologists, who are the experts in communication and swallowing disorders. So those specialists help patients improve their language and communication and social communication. So physiatrists are really the leaders of these teams. We're the ones who actually prescribe these therapies. So just like other physicians might prescribe a medication, we end up prescribing the PT, OT, SLP. We also work closely with patients to provide them with adaptive devices as needed. So we provide them with prosthetics, which are artificially made limbs that replace a part of the body that is missing, or orthotics, which are devices that are used to correct or enhance the function of a body part. And we perform other procedures such as acupuncture, platelet-rich plasma injections, which are relatively new. Some of these things we still need additional randomized controlled trials to show the efficacy of, but those are also things that you can get training in as a physiatrist. So I'm going to talk you through a few case studies to give you an idea for what it is like working as a physiatrist and the breadth of patients that we see. So the first patient is one that you would see if you're working on an inpatient rehab unit. And the second one I'll go over is one that you would see if you're working in an outpatient clinic setting. So the first patient I'm going to tell you about is a 49-year-old male. He has a history of leukemia, and he's coming to inpatient rehabilitation for deconditioning and hospitalization after COVID-19. So very related to current events. Patient we recently saw as well too. And I'm going to give you a little bit of background and medical history on him. He was otherwise healthy except for this diagnosis of chronic myeloid leukemia with blast crisis. That was diagnosed in early January of 2020. And he underwent 5 cycles of chemotherapy and was otherwise doing fine, staying active, working in his yard, thinking pretty clearly until September of 2020. And at that time, he was brought to the emergency department with a week of generalized weakness and confusion. He couldn't give us a clear history, but his wife said that he was slow to respond to questions, making no sense and doing nonsensical things like putting towels in the toilet. And so he was admitted to the hospital where he underwent an infectious and cancer workup, things that included a chest x-ray, urinalysis, CT of his head, and that was all negative for other causes of his symptoms. And the only thing that was positive was his COVID PCR. So while he was in the hospital, he was seen by many different specialists. They felt that his altered mental status was unrelated to his leukemia or recent chemotherapy, and they really ruled everything else out and felt that his confusion was due to neuropsychological sequelae of COVID-19 infections. So after this acute hospitalization, he was sent to us in inpatient rehabilitation. And before going further, I just wanted to take a moment to recognize that there was a lot that had happened before we as physiatrists even saw him. he was in the hospital and he was seen by all these different specialists. He underwent a lot of workup and different tests, and a lot of different other medical causes for his confusion were ruled out. And even though all of this happened before we see him, it's important for us to understand how understand his medical course, because that sheds light on his recovery. So how long he was in the hospital and what complications he might have had, if any. Those are things that would give us an idea for how deconditioned he is and how much therapy he might need. So now that we have read about his history, some of the reasons he's coming to us in a patient rehabilitation, including the following listed on this slide. So he's had decreased strength. He's had more dependence with his ADLs and IADLs, as well as cognitive impairment. So ADLs, that stands for activities of daily living. Those are things like eating, bathing, getting dressed, toileting, and going to the bathroom. And IADLs stands for instrumental activities of daily living. So these require slightly more complex skills, and they include things like cooking, driving, caring for pets, completing housework, managing finances. They're essentially like more complicated ADLs. And both of these things, ADLs and IADLs, as evident in their name, are important for daily living. So it's important for him to be able to maintain independence and go back to living in his own home. And also cognitive impairment, that describes an impairment in his ability to think and plan and make decisions in his everyday life. So all of those things are reasons why he is coming to us in inpatient rehabilitation. So once he arrives on our floor, we go and meet him and meet his wife, and we've already read through his medical chart, so we understand what happened before he got to the hospital. And so now it's time to really get to know him and to understand what he was like, what his life was like before he came to the hospital. So some things that we care about are his social history. That basic social history includes things like how much he smokes, drinks alcohol, or does other drugs. But also, as physiatrists, we especially care about other aspects of social history, like his level of education, which can impact what his cognitive baseline actually is. His employment, so does he currently work? Was he previously working? Is he planning to go back to work? What does he do? Is he doing a job that requires intricate use of his hand muscles? Is he up and walking around all day? So might he need an assistive device or accommodations at work? Those are all things that we think about. And we also ask about his hobbies and how active he is, because our goal is to get him back to doing all of these things. We also want to understand his living environment. So how many steps he has at home. Will we need to get him back home where he'll have to climb stairs? Does he live in an apartment building where there is an elevator? Does he have a tub shower or a shower with railings so that he doesn't fall and slip after he gets out of the shower? So things like that help us understand whether he will be safe at home or whether he'll need assistance like home health services or family training if family is going to be with him. And then we also want to understand his functional status. So is he and his wife, are they expecting him to go back to what he was doing previously? And what is he doing right now? So how far is he from this goal that he and his wife have? And is this goal realistic? So for our patient, we find out that he's a non-smoker. He doesn't drink. He works on a 7-acre farm in Middle Tennessee and was very active on his feet, driving a tractor around. So he's pretty independent before he came to us in the hospital. And he lived with his wife and 2 young children who all depended on him. So knowing all these things, we then do our physical exam. We assess how he's doing right now. So for us, we really focus on his strength and musculoskeletal exam, as well as his neurologic exam. So there's different specialized exams that we can go into to kind of help us better understand his neurologic status. But generally speaking, for the purposes of right now, we'll just mention that musculoskeletal and neurologic exam are the important things that we want to focus on. So he has some weakness in his arms from being deconditioned in the hospital, as well as his legs. He has been walking around the acute care hospital, but required use of an assistive device. He will need to work with physical therapy to improve his strength. And then cognitively, on his neurologic evaluation, he was very far from his baseline. So he needed maximal cueing for simple commands, and he had difficulty initiating tasks. He was also very fidgety and distractible. So for these things, we'll also need him to see neuropsychology as well as speech language pathology to work on speaking and communication. So our job as physiatrists, while he's in the hospital, is to prescribe these therapies to monitor his improvement over time. And if anything medical comes up while he's with us, such as if he becomes agitated or confused, or if he has pain from working in therapy, we as physiatrists will also work this up. So in a sense, we're the primary care physicians in this inpatient rehabilitation hospital. We're kind of like the hospitalists who oversee the patients as they're doing their rehabilitation. And the last thing that we kind of emphasize for all patients in inpatient rehabilitation is that rehabilitation is an ongoing process. So we really see him for a slice of time, and we see most patients for a slice of time in this intensive inpatient rehabilitation setting. For him specifically, there are a lot of neurologic manifestations of COVID-19, and recovering from COVID-19 or from any disease can take time, with the trajectory being different for different patients. So we often continue to see these patients as outpatients in clinics or in outpatient physical therapy as well too. So even after he is discharged from our unit, we continue to see him and follow him longitudinally. Next, we're going to talk about what you might see if you are an outpatient rehabilitation doctor. So we'll talk a little bit about more about the MSK, musculoskeletal aspects of PM&R, and specifically we'll be talking about knee pain. So this is in a 19-year-old runner who is coming to our clinic. And before I get any further talking about our second case study, I'm going to go over a little bit of anatomy. So that's very important for physiatrists, and just kind of big picture anatomy. And I always review this before I go in to see a patient as well, since I'm still a resident. But just go big picture anatomy. The knee is a modified hinge joint, and it's the largest joint in the body. It's especially susceptible to injury because sorry about that, everyone. I guess my internet cannot handle this. So I'm back on my phone, my iPhone now. So hopefully we have steady internet. Let's see, go back. Sounds like I'm just popping in and out, but let's see. If I go like that, do that. Okay. Are we back to where we were? Okay, perfect. Thank you guys for being patient with me. Clearly, internet isn't one of my greatest strengths here, but we'll just kind of keep going forward. So back to talking about the knee. On top of the knee, there's the bones. On top of the bones, include the muscles, which are the knee extensors or the quadriceps, the flexors, which are the hamstrings, and that's made up of several different muscles, as well as your rotators. And then there's also the popliteus muscle, which unlocks your knee. But that's kind of the big overview picture of the muscles on the knee. And then you have the ligaments of the knee, and that includes the ACL, PCL, MCL, and LCL. So that's kind of your big picture knee anatomy. Now we're going to jump back into the case and get more of a history from our patient. And when obtaining a history, we use the mnemonic OPQRST, which I apply especially to patients who come in with pain, and that gives me an outline for how I'm going to ask questions to understand a patient's history. So in this patient, the knee pain or onset began several months ago. It is worse or provoked, so that's the P, with walking down the stairs and running up and down, running down hills. The stiffness in the knee is worse after sitting for a long period of time. She often hears a popping or cracking sound in her knee after prolonged sitting. And the pain is also located at the front or anterior region of the knee. On a scale of 1 to 10, she rates it as a 5 in severity. So from here, we do our physical exam. We take a look at the knee and we'll assess for areas of tenderness, amount of swelling, as well as range of motion. We can also do specialized knee tests if we're concerned about specific diseases. So there's a lot of different tests that you can do. But one of the fun things, just to put on your radar, one of the fun things about musculoskeletal medicine is that you can get a lot of information based off of physical exam. And those are things that you really get to continue working on throughout residency as well too. But regardless, at the end of the day, and oftentimes in a lot of patients, we go ahead and order imaging. So we get an x-ray, and that helps us detect if there are fractures or bony abnormalities. In our patients specifically, the x-ray helps us visualize the location of the patella on the femur and detect any early arthritis, which in her case, she's quite young for that. But those are some things that the x-ray can. And workup, we end up diagnosing our patient with patellofemoral pain syndrome, which is also known as runner's knee. So PFPS is anterior knee pain that is caused by improper tracking of the patella along the distal femur. On the image on the right, you can see the patella against the femur, and improper tracking against that improper movement can cause this sort of pain. So by taking x-rays at different angles, we're able to see when her kneecap goes off track. But also our suspicion for PFPS is high based on her history because she is a runner with knee pain that is worse when going downhill. And a lot of our physical exam will help us kind of get to this diagnosis. It's actually a very common complaint, PFPS. It's very common in young women, especially runners, and it results from a combination of structural factors as well as muscular imbalance and quadriceps weakness. So finally, we get to focus on treatment. And a lot of this will involve activity modification and correcting any incorrect running form or mechanics that can be contributing to the pain. Rest and ice, as well as NSAIDs like ibuprofen, are really the foundation for any musculoskeletal complaint. And then there's physical therapy. So it's important to her to strengthen quadriceps as well as stretch the hamstrings and adductors as well. So those are all things that we would end up prescribing physical therapy wise. She could also consider bracing or a patellar knee sleeve. And then a lot of other things that physical therapy can work with her on as well too. And so really we manage her non-operatively, and oftentimes we can get patients back to running, back to doing their sport. Consulting to surgery or orthopedic surgery is really our last resort. All right, so now that we've had 2 case studies about patients that you would see in physical medicine and rehabilitation or physiatry, we're going to go back to talking about becoming a physiatrist. So physiatry, it is a medical specialty. After high school, there are an additional 12 to 13 years of training in order to become a physiatrist. And that includes undergrad and medical school. And after you graduate medical school, every physiatrist is required to do 1 year of an internship, which is usually in internal medicine, but some people do it in surgery or like do a transitional year, which is like kind of like a combined internal medicine surgery year. And then residency is 3 years, but you can do up to a 1 or 2 year fellowship if you'd like as well too. Fellowships theoretically are optional because we are a specialty, so you should be able to practice all the scope of physiatry without a fellowship. But for those who want to get a little bit more training, there is the option for a fellowship, and a little under half of physiatrists, so about 43%, actually end up completing a fellowship. And so I think that I'll just mention briefly what residency is like, since people ask me about that. And, I don't know how relevant it is for you guys, but just kind of go over it really quickly. Residency actually tends to be pretty fun if you're in physical medicine and rehabilitation. Our programs are pretty small, and most of the programs range in size from 2 to 14 residents per class. So in my class, there are a total of 4 of us. Completing residency after your intern year is pretty simple in terms of the requirements that you have. You have to do 12 months of inpatient and 12 months of outpatient. So for the 12 months of inpatient rotation, here are some examples of what you might be seeing. You could be managing general deconditioning, neurologic disorders, as well as brain injury and spinal cord injury. As far as outpatient rotations, you have 12 months of required outpatient. Here are a handful. And it really depends on the program and what they offer, but this can include amputee clinic, EMGs, spine, and sports. Those are some of the popular electives. And then after that, you have 12 months because it's theoretically 3 years after that internal year. And depending on your program, that's a combination of inpatient as well as outpatient months. Let's see. And in residency, you have a maximum of 6 months for research. If you're very interested in becoming like a scientist physician, there's a program called Rehab Medicine Scientist Training Program, or RMSTP, and that allows you to become a researcher and teaches you how to obtain NIH and other research funds if that's where you're thinking your career is more going to lie. And so long story short, there's a lot of time to be involved in other extracurricular opportunities. Call really depends on your program, but I take about 8 weekend calls a year as a PGY2. And that lends itself to having time to be involved with other things, such as recruitment and helping with incoming residents and working with medical students to spread awareness for our field. I do other things such as research and sports medicine research specifically. And one thing that I think is pretty unique as well too is that I've been working closely with the Entrepreneurship and Design Center at Vanderbilt. So in conjunction with the business school and with some PhD students, with my background in product design, I have been very interested in healthcare technology as well as entrepreneurship. And I've been fortunate enough to have the opportunity to do some of those things even as a resident. So I've been mentoring some health tech startups with other PhDs and MBA students, even here as a resident. So one of the really great things I think about PM&R that I've found is that you are able to build your career even as a resident and kind of start to do things that many attendings like to do in other fields as well too. So another thing important to think about is life after residency, and I'll just go through this very quickly. As mentioned, a little under half of residents actually choose to pursue fellowship. And if you want that extra training, here are some of the extra fellowships that you could pursue. So I've grouped them into 2 types, the ACGME accredited and the non-ACGME accredited. ACGME accreditation, it's an accreditation council for graduate medical education. And it's essentially composed of a review committee that sets standards and provides assurance that certain programs meet quality standards. So some of the ACGME accredited specialties include hospice and palliative care, spinal cord injury, sports medicine, and traumatic brain injury. Some of the non-accredited, newer perhaps fellowships also include cancer rehabilitation, neurorehabilitation, interventional spine, as well as research. So what is life after all this training? Depending on what kind of career you want to choose within physiatry, you can work in a variety of environments, including inpatient and outpatient settings and consulting roles. We practice in academic settings, group practices, as well as solo practices. And some of the places where you might see us include a sports medicine clinic, neurology clinic, an acute care hospital, a rehabilitation hospital, skilled nursing facilities, and others. As I'd mentioned earlier, PM&R is a team sport, so we work with a team of other medical professionals, and you might interact with other physicians that include neurologists and orthopedic surgeons. We also lead that team of healthcare providers, as mentioned earlier, which include physical therapists, occupational therapists, respiratory therapists, and nurses. So there are many reasons to choose physiatry, only some of the reasons I have listed here, but it's a very meaningful specialty and it can lead to a very meaningful career. So whereas most patients don't want to be in a hospital or don't want to see most doctors, most of our patients are excited to see us because they want to get better. It's also incredibly meaningful to work with patients all along the age spectrum, some who are young or old or who have just suffered from a traumatic event. It's rewarding and fun to help them adapt to their new disabilities and get back out to living their lives. We build very meaningful relationships with our patients. They're very motivated and they want to get better. And as I briefly mentioned as well too, you can work with a very diverse patient population. So you really can choose the type of patient you want to work with. You can specialize in pediatric rehabilitation. There's a huge need for that. You can work with Olympic athletes if you wanted to. You can specialize in women's health and pelvic floor rehabilitation as well too. So you can really choose the patient population that you want to work with, but you don't have to. Physiatry is also a multidisciplinary field. So if you like neurology and musculoskeletal medicine, you can do both as a physiatrist, and you get to work in a team with other physicians, and you can lead a team of healthcare providers. And then lastly, physiatry is full of opportunities. As a new and relatively lesser known specialty, you can make it what you want it to be. It's, of course, getting more competitive each year, and we are actually one of the few specialties that have gone unmatched. So that's along with, I believe, orthopedics and dermatology, but more and more each year, people are finding out about our field and getting more excited about it. It also gives you the opportunity to have significant work-life balance, and that's another thing to consider too, especially, depending on how you want to spend your free time, whether that's doing other things outside of medicine, such as working with health tech companies, or even spending time with your family. You have that time and opportunity within physiatry. And lastly, I want to just conclude by giving you all 3 pieces of advice. So these are some of my pieces of advice for students. My first piece of advice really is to pace yourself. So everyone says that medicine is not a marathon, medicine is a marathon and not a sprint. And it truly is. When you enter the field of medicine, you realize that exams never end. And I just took my final step board exam, and then I realized that I was getting ready to take in-service exams. And then you start studying for the next exam, and really it never ends. I think that when I was in college, I always told myself that once I figured out what I wanted to do, and once I figured out my career, I could finally be happy. And then I figured out that I wanted to go to medical school, and I kept telling myself that once I got to medical school and I finished medical school, I could finally be happy. And in some ways, I kept using that next big accomplishment as an excuse to not really enjoy the moment. And so that can get to you. And now that I'm a resident, I realize that these exams and the need to continually achieve and get that next thing in life, that never ends. So you really have to be happy with what you're doing in the moment, and really make sure that what you're doing is something that you enjoy. And when you do all of these things, I think it opens you up to be willing to embrace opportunity. So that's my second piece of advice, is to embrace opportunity. When I got to Stanford, I really kind of felt out of my league with a room of very smart people. I kept comparing myself to others because I was searching for my passions, not really knowing what they were. And I ended up trying a lot of different things. But had I not embraced the opportunity to major in product design, and had I not taken that lifestyle medicine and musculoskeletal medicine class that was taught by physiatrists, I probably wouldn't be doing what I am doing now. And I also think that people with the most interesting careers and people who have the most interesting stories to tell have been those who have tried many different things and found ways to combine different disciplines. So I've tried to emulate my career after some of these people, and really tried to embrace the things that pop up, the opportunities that I have found interesting. And then lastly, this is kind of more of a cheesy one, but make time for your friends and family. Keep them close. When I went to medical school, I ended up living with my parents, and that was probably one of the best decisions I've ever made because I was very spoiled. They took a lot of time for me, and they took good care of me. And as a resident, I now live very close to my in-laws, and I continue to also keep them very close. I try to make time for my college friends and try to see them where I can. Obviously it's very difficult now with COVID, but it's so important because without your friends and family, I wouldn't be where I am today. So all these things I think are important things that, looking back, things that pieces of advice that I would have given to my younger self. And I'm here just attaching some references and resources here if you're interested in learning more about our field. And I know that a lot of you are still kind of trying to figure out what you want to do and are early in your career, so feel free to reach out to me. The easiest way to reach out to me probably is on Instagram, or as a lot of us like to know it, Medstagram. So you can message me there. You can also follow me on Twitter, shoot me an email as well too. But probably the easiest way is to message me on Instagram. I'm happy to take any questions if you have them, or we can end a little bit early as well too. All right.
Sorry, we have someone who's raising their hand, but I'm not sure if they can unmute. You guys can just use the chat if you can't unmute.
Oh, okay. And I see here, I'm not going to chat, so let's see. So I think the first question, and I'll just kind of go through them as well too. How would a PA be involved in PM&R? So that's a great question. I have some very good friends who are PAs actually as well too. And being involved in PM&R, so we work very closely with nurse practitioners as well as physician assistants. I've seen physician assistants more so in the outpatient setting, so in like the orthopedic setting, musculoskeletal medicine setting, but I'm sure that there's a room for them in like inpatient rehab. Within the inpatient rehab, we work very closely with nurse practitioners. They end up kind of being like a, in some ways, like kind of like the resident. So they help out a lot with what we as residents do. Oops.
I didn't get that.
My bad. With what we as residents do. So they help out with a lot of the note writing. Ultimately, their job is to really, do kind of help, kind of be under the attending, and they need to be overseen by an attending. So they help out with a lot of the notes, and that makes it, in some ways, a lot better for us because we can focus on the learning, we can focus on treating the patients. So we work closely with nurse practitioners and PAs, and we see them also as our colleagues. Like I have a good friend who's a nurse practitioner, and I kind of see her as my colleague. So, all right, let's see. Answer this one. What is the most difficult part of being a PM&R physician? I think, so some of the things to consider for sure about PM&R is that not everyone knows what you do, mostly because the spectrum of our specialty is so broad. That's also a big reason why a lot of people choose to specialize within a part of PM&R. So whether that's, for me, like sports medicine or traumatic brain injuries and concussion management, or working at a SNF and doing more of like a hospitalist internal medicine type of PM&R role. I think one of the hardest parts about PM&R is describing to other people what you do and what you see. I think PM&R is a great field for those of us who really know what we want to do and can go after it. But it's a little bit less, in some ways the path is a little bit less defined. So that can be both a good and a bad thing. But I think that's one of the difficult parts. And oftentimes people will ask us, what does a physical therapist do versus what does a physiatrist do? And kind of explaining to them what, what value we bring is something that can be difficult. Let's see. Here's another one. I think what kept you going when you felt the need to give up, I think is what they're asking. I think that's a good question because I think it never really ends. Like there's, I think there's always, as you get further and further in your career, especially with everything that's going on right now, COVID is a very difficult time as well too. And I can only imagine what you all are going through, especially because COVID, I'm sure, is limiting so many opportunities. I think making time kind of, making time for your friends and your family, finding outlets as well too. So I'm a big runner. I run every other day of the week. And I just make time to do things that aren't necessarily related to working all the time. So I think if you figure out things that you can do outside of medicine and outside of healthcare that you're passionate about, I think that'll keep you going. And then also making sure that every step along the way, just reevaluating and asking yourself if this is what you want to do, if this is going to get you where you want to do, will help kind of reinvigorate and re-inspire you. That's what has worked for me. What does your day-to-day life look like? So right now I'm a resident, and as a second-year resident, we work mostly on the inpatient rehabilitation floor. So day to day, we have didactics starting at around 7 a.m., 7 to 8. We start rounds at around 9, between 9 to 10. So after the patients have gotten their morning medications and while they're in therapies, because we like to see them when they're in therapies, we round in the morning. Rounds end at around 11. And then we have, time for didactics and time to put in all of our orders and write all of our notes. In the afternoon, that's when we get most of our admissions. And so usually we'll get like 1 to 2 admissions. And if we don't have an admission, your day you kind of wrap up everything by 2 or 3, but you're theoretically supposed to be there until 5 p.m. just to make sure that your patients don't decompensate or something, things don't come up. But if your patients are pretty stable, then you're kind of done for the day. If you get an admission, usually you're there until 5 or 6 p.m. So most of our days run from 7 to 5 p.m., 5 to 6 p.m., some days later, some days earlier. And outpatient, similar schedule as well too, but you're in clinic that time. So any classes in high school that would be beneficial in PM&R? I think a lot of, if your high school offers like musculoskeletal medicine type classes or neurology, like, I don't know, like neurosciences can be very helpful as well too, because PM&R really is neurology and MSK. And if you have strong foundations in both of those fields, that can be really helpful. A lot of people actually go into PM&R after they've had training as like a health coach, or after they've done, I think we had one who was like previously a bodybuilder and then went into PM&R, but kind of like those health sciences, like physical therapy, musculoskeletal medicine, as well as neurology classes are beneficial for our field. So, yeah. So what would you say are the best qualities of being a good doctor? I think getting through, so let's back up and talk about what gets you through medicine and then what makes you a good doctor, because I think that oftentimes those can be not necessarily conflicting, but it can be really difficult, because getting yourself through medicine and through medical school is one step, and then being a good doctor is another step. Getting yourself through medical school, I think that is actually, if you're passionate and if you're willing to work hard and really, really study, that's a lot, it's a lot more achievable than a lot of people think. So if you're dedicated to going to medical school and you love, the health sciences, you love being a doctor, you really just have to get yourself through all of those exams, and you have to make time to study. And once you get far enough, as long as you study and you're a good person and you can pass the exams, you will make it, despite it being a very long route. But the qualities of actually being a good doctor, I think as we get further in our training, we start to lose some of that empathy, because we're just forced to write so many notes and forced to take so many tests. But then at the end of the light at the end of the tunnels, then we start to see, once we get through all this, and once we get through all the note writing, and we have teams to help us, whether that's our residents or our nurse practitioners or our physician assistants, really making time for the patients and understanding them and hearing their stories. I think being able to combine all that medical knowledge, as well as being able to maintain your empathy for patients and taking the time to sit and listen to them. If you're able to do both of those things and combine those two things, then I think that's what makes for a really successful doctor, because at the end of the day, you can know all of the medical knowledge in the world, and perhaps your calling is research, and perhaps your calling is advancing medical knowledge, but being a doctor who is there for your patients that requires you to be able to sit down and talk to the patients and relate to the patients and have a way of talking to patients so that they actually take your advice and listen to the things that you're telling them. So yeah. So let's see, I'll give it maybe a few more seconds, and then if there aren't any questions, maybe we can all end a little bit early today. I don't know what you all think as well too, but yeah. All right, so looks like you all, still Sunday for you all, and I don't know if you're all taking virtual classes or what, but feel free to reach out to me if you have other questions, other personal questions as well too. And thank you all for being here. Best of luck with everything. I know it's a really difficult time, and I know that I speak for a lot of people when I say that we all want to be able to be here to support you all as well too. So.
Thank you so much for coming to talk to us today. Your presentation was really informational, and yeah, just thank you again.
Of course, thanks for having me. We'll see you all later.